Okay, we're going to proceed now with bacillary dysentery, what is commonly known as shigellosis. So it's still part of the fecal-oral diseases that we're doing under the infectious and vector-borne diseases series. So as always, kindly remember to subscribe. So to start us off, we're going to look at what this Shigella is, or what shigellosis by definition is. It's basically an acute bacterial disease of the intestines that is normally characterized by inflammation of the intestines, and ultimately you have bloody diarrhea. Okay, so it is normally termed as disease of the poor and the crowded communities. Even though nowadays things are changing, it is the most important cause of acute bloody diarrhea. Okay, so as we'll proceed, you'll see we have other fecal-oral diseases like cholera, which is case definition basically is acute watery diarrhea. Now, in the case of Shigella or bacillary dysentery, it's normally characterized by acute bloody diarrhea. From the start, I want us to know that this one is bacterial, okay, as opposed to what we've done in amoebic dysentery. Amoebic dysentery is caused by a protozoa. Okay, a protozoa, that's different from bacteria. Okay, so etiology basically, since you've said it's bacterial, the bacteria itself is a gram-negative aerobic bacilli, which is non-motile. As you can see, no flagella. So basically, no movement, even internal flagella is not there. So they're gram-negative. And as you'll notice that most of these causative organism or bacteria basically that affect the gastrointestinal system are normally gram-negative, but obviously there are exceptions in every rule. So the Shigella species that normally cause bacillary dysentery, we can look at them from four types or four species. So we have Shigella sonnei, Shigella dysenteriae, Shigella flexneri, and finally Shigella bodi. However, the first three, that is sonnei, dysentery, and flexneri, are the most common causes of outbreak of acute bloody diarrhea, which is bacillary dysentery. So the mode of transmission, similar to most of the other fecal-oral diseases. So it's transmitted via the fecal-oral route, that is either through flies or contaminated hands, or indirectly through dishes which are poorly washed, or by water which is contaminated. So the Shigella multiply in food, which when ingested normally causes the dysentery. So humans are the only reservoir for this outbreak. Okay, and the incubation period is normally very short. That's why it causes acute disease. So 1 to 4 days. Normally within a day, you've had food that is normally is already contaminated with Shigella. You will normally not even finish 24 hours before you start having the clinical picture of this dysentery. Okay, so the the four the 4F's correction basically is to show us basically about how we'll get this infection, and we have flies that will contaminate, we have feces that has this bacteria, then we have fingers that are dirty and maybe contaminated, and food which is also contaminated. All of this, they're taken orally, or if they contaminate things that are taken orally like food, then we end up having the disease. So you see feces, maybe having the bacteria, then flies like step on them, and then the flies end up on food, or fingers, or whichever way, end up touching the feces and touching the food, which then ultimately ends up in the mouth. So how does it cause disease? Basically, once the bacteria, so you notice, first of all, you've not looked at like a life cycle, because bacteria, basically we don't look at the life cycle, since once you're infected, the bacteria doesn't change form whatsoever. So it just carried from the source and then goes to the site where it's going to cause the disease. So nothing much changes with the form or the state of the bacteria. So when the bacteria gets into the intestines, um, that is how we start having the disease. So the infection is by ingestion. Obviously, we get the bacteria in by the ingestion. Then it invades the colonic mucosa. So the mucosal layer of the colon is invaded. Then you have local spread of infection, and then it causes the death, or it destroys basically the epithelial cells. Okay. But one thing that is important with Shigella is that it produces toxins which kills the cells. So basically, it is not the bacteria itself that destroys the cells; is that the bacteria produces toxins. Okay, and these toxins are the ones that they kill the cells. And this is common mostly for most gram-negative bacteria. Okay, they normally produce endotoxins which now cause affected the cells. So the mucosal membrane of the colon becomes inflamed, and then they start bleeding. Okay, and with patches of necrotic membranes being formed. So this normally leads to ulceration of the areas of the intestines. So I want you to understand that once you get the bacteria goes and invades the colonic mucosa. Okay, then it produces these toxins. The toxins destroy the cells of the mucosa or the epithelial cells of the colon mucosa. So, what is the effect of this pathogenic process? Is just the onset is normally very sudden. Okay, as you realize, maybe compare it to things like amoebic dysentery, is that it takes time for the protozoa itself to start causing all these problems, because it needs time to start replicating, to reproduce, and by the bacteria reproduces far much faster. So you expect that in bacillary dysentery will have this thing the onset becoming very sudden. Now, because of the release of the endotoxins, we normally have fever, and then we'll have headache, diarrhea, and then because of the destruction of the mucosal layer of the epithelium, then we have streaks of blood and colic abdominal pains. So normally after a few motions, the diarrhea stops, and it is normally followed by very severe pain, abdominal pain. Then you'll have tenesmus. Then the patient passes a small amount of purulent mucus and blood. Okay. Yeah. So the toxins produced by the Shigella may be absorbed into the bloodstream, resulting in toxemia. And the toxemia is what causes the high fevers and the rapid pulse. Okay. So dehydration is also common and dangerous, maybe because of the destruction of the colonic membrane, and then you have loss of fluids, and then you have dehydration leading to cramps. Okay, if this persists, you can have a shock secondary to the dehydration. And in infants, because of the tenesmus, you feel like they want to pass stool even when there's no stool. We can have rectal prolapse, and then other things like convulsions can also occur because of the high fever and the toxemia that is building up. Okay, so just to understand the differences between the bacillary and amoebic dysentery, which is very important, is that bacillary dysentery is very acute. So the incubation period is very short. We said like around 1 to 4 days, and then amoebic dysentery takes longer. Okay, 3 weeks. So it's a bit onset is a bit insidious, gradual, and what have you. The fever is common in bacillary dysentery, and then in amoebic dysentery it will only occur if we have the protozoa leaking into the blood. So it's only in a complication. Okay, then we have clinical picture where the dysentery, you have lying down dysentery, and then you have walking dysentery. This is just to show them the severity. So in bacillary dysentery, the pain or the dysentery itself, it will be so much that you cannot basically even walk straight. So you have to like lie down or something to feel better. Walking dysentery means you can be moving, but you're having some discomfort. Abdominal tenderness is in the whole abdomen here, most localized in the sigmoid. And the reason is because what we're releasing here is the toxins, which basically will affect most areas of the colon. As opposed to amoebic dysentery, it's basically focused on where exactly the trophozoite is actually causing the ulceration. Then this is very severe, as I think I've explained here. The tenesmus is not very severe in this case. Then stool, there's mucus and blood only. Okay, that pus might be present, but mucus and blood only in bacillary dysentery. Then, because the stool is not too much here, in amoebic dysentery, you'll have stool that has blood and mucus. Okay, so that's a good difference you should be able to pick up. Microscopically, you'll have numerous RBCs, and then you'll have also numerous RBCs clumped together, and also you'll have polymorphs in both cases. Okay, so they are quite different. Also, you can add that bacillary dysentery is caused by a bacteria, okay, of the Shigella species, and then amoebic dysentery is caused by protozoa Entamoeba histolytica. So you can have more differences, like dysentery, the number of motions you might have in a day. Amoebic dysentery, which is more severe, have more than 10. The amount of basically stool you produce here is copious, because remember in amoebic dysentery, it will have stool which has mucus and blood, but here you'll have mostly mucus and blood, so very little amount of stool. The odor of the stool is a bit offensive, odorless, because again it's very small, dark red, but in bacillary dysentery it's bright red. Then most importantly, you should just know the ones that we've talked about here. So the nature, we've said blood and mucus mixed with feces, but here in bacillary dysentery, we have very little amount of feces or no feces, but we'll have blood and mucus. Okay. So diagnosis is basically through, remember this bacteria. So stool culture for Shigella species. And then stool examination, which shows the presence of blood and mucus, and also stool microscopy to show the presence of large numbers of the white blood cells or erythrocytes. But just basically the stool culture will do. Management. So mild bacillary dysentery or shigellosis is self-limiting. Maybe what you need is a bit of rehydration. But when it's severe, it's not something that you really need to handle very fast. So rehydration is also very important, very important. But antibiotics also, we normally give ciprofloxacin orally or nalidixic acid. For the pain, you'll have to do some analgesics like paracetamol, then rehydrate using fluids if they can take it orally, okay, or IV fluids, depending on the level of dehydration you're talking about. Then to reduce the amount of the urge, the tenesmus of passing stool, we can do loperamide. It can be given to decrease the amount of motility. Then maintaining adequate level of nutrition is also very good. Okay. Now prevention and control is basically the same thing we've been talking about for fecal conditions. Safe water supply. Okay. Then we improve personal hygiene, digging of using pit latrines, also food hygiene. Then health education basically on environmental hygiene, and also breastfeeding, especially for mothers who have young kids. And also in public eating places and markets, boarding schools and camps. It's important also these people are actually, this area is actually inspected to ensure that they are free of the bacteria or the ways that actually it can be propagated. Okay, so thank you very much. Hope you enjoyed and actually you learned something about it. So feel free kindly to subscribe to get more videos.